Ma'am, we are live now. I request your permission to start with the session, ma'am.
Yes, please.
Thank you, ma'am. Hari Om, everyone. A warm welcome to the 25th session of Ayur Anatomy, LHS series for the first year BMS students. The exclusive sessions will be taken up by the eminent speakers of anatomy across the country for a period of 30 days, which started from 23rd of June and will be running up to 19th of July. Before starting the session, let me introduce you to Jignasa. Jignasa is a pan-India platform of Ayush fraternity led by the student community of Bharat and was initiated by ABVP in the year 1998. Its motto is Learn Ayush to Practice Ayush. It involves empowering Ayush students from campus to community, bridging the gap between Ayush students and policymakers as well as administrative authorities, connecting every aspect of Ayush students, academicians, practitioners, scientists, industrialists, and hospitals all under one umbrella. Think globally, act locally. In last 2 decades, our efforts were to strengthen the Ayush education system and boost confidence among Ayush students. Jignyas initiated various programs in different parts of the country, from grassroots to international platforms, through discussions, study circles, seminars, workshops, and conferences. Let me list a few initiatives undertaken by Jignasa. Study circles, lecture series on specific topics, free medical camps, social health status survey, hands-on training workshops, conferences to explore and learn unique aspects of Ayurveda, interaction with eminent Vaidyas and academicians, brainstorming sessions with Ayush stalwarts, policymakers, and key stakeholders of Ayush systems, National Arogya Expo and International Conference, national level seminars, medicinal plant visits, pharmaceutical visits, agitations for the demands of high student community, private internship program for interested students to learn with acharyas, interaction with traditional leaders and workshops of high systems, organization of workshops for social welfare like Swarna Bindu Prashana Camp, Group Surya Namaskara, Ashto Shatatri Yoga, and other yoga competitions. Free healthcare assistance to people through local governing bodies during natural calamities and accidents were also provided by Jignasa. In our yesterday session, more than 700 students joined for the live session and asked their queries regarding the subject and examination. And so far, we are proud enough to say that we have received more than 18,000 views for our videos and iron anatomy. We hope to reach as many students as possible who can take maximum benefit out of this. Vidya Navanarasya Rupam Adhikam Prachana Guptam Dhanam. We have seen the inability of common students to afford huge amounts on commercial study platforms despite their jignasa, the burning desire to learn. Jignasa is here to give a helping hand, learn anatomy with experts, and all we need is your immense interest to learn. Today, we have Dr. Kochitrias Joseph Ma'am, BMS MD Rachana Sharira, Assistant Professor Rachana Sharira in SDM College of Ayurveda and Hospital Udupi. Ma'am completed her UG from ALN Rao Memorial Ayurvedic College Koppa and PG from SDMCA Udupi. And PG thesis was a critical analysis of Kala Sharira with special reference to Mamsadhara Kala. Ma'am secured first rank in PG with gold medal, and so far ma'am has published 3 papers, and total of seminars attended and webinars attended are 15 in number. We welcome you to the session, ma'am, and each and everyone who is watching this. We hope you find this helpful. Thank you, ma'am. Now we request you to carry forward with the session.
Okay. Thank you, Mr. Karthik. I'm really glad to be a part of Jitnyasa, this study series. And I really appreciate from the bottom of heart the Jitnyasa all family, the Jitnyasa group for the best effort you are putting for the students of BMS. So with that introduction, let me start my today's topic. My topic being assigned is arthrology. Arthrology. So points in syllabus, that is as per our NCSM syllabus, new one, it is under must to know topic and comes under paper 1, and total marks allotted is 10 marks. It can be asked in long essays, short essays, even for the MCQs. So the points in NCSM syllabus are classification of joints, structure, types and movements, movements of synovial joints and structural aspects helping in movements, then constitutional anatomy of joints, joints of upper limb, lower limb, intervertebral joints, and temporomandibular joints with their applied aspects, and the examination of synovial joints. Coming to the related terms of joints, that is arthrology, there is a word called as arthron. This is a Greek word, means a joint, from which the arthrology or arthritis, the term has been derived. Next, articulatio, that means articulation or the junction. Then junctura, it means a joint, and syndesmology is a term related to ligament. The study of ligaments and related joints is called as syndesmology. So, coming to the definition and functions, the study of joints is called as arthrology. A joint is a junction of two or more bones or cartilages. Their function is movements, forms cavities, and protects the organs and transmission of weight to the ground. The movements means we are having a lot of movements like flexion, extension, lateral rotation, medial rotation, dorsiflexion, plantar flexion, etc., movements, and it forms the frame cavity. The bony frame will be joined together with joints so that it can protect the vital organs. For example, lungs, the heart, the abdominal organs, those things can be protected in a proper way. And it facilitates the proper movement as well as the weight transmission to the ground. So coming to the classification, for exam point of view, it is very, very important. So first one is structural classification, next one is functional classification, next one is regional classification, and finally the number, according to the number of articular bones, the classification. So structurally, it is of three types: fibrous, cartilaginous, and synovial. Functioning, they are synarthrosis, that is immovable, amphiarthrosis, slightly movable, and diarthrosis, that is which is freely movable joint. Coming to the regional classification, there is a skull type, vertebral type, and the limb type. Skull type means that's immovable joints of the skull. Vertebral type means that's a joint, but it allows only a slight variety of movements. Coming to the limb type is a freely movable joints. So according to the number of articular bones classification, there are simple joint. Simple joint means two bones are articulating with a simple joint. That is called a simple joint. And compound joint is more than two bones are articulating. Complex joint means more than two bones are articulating. Along with that, the joint cavity will be subdivided into certain compartments along with articular disc, menisci, etc. So we will move on to the description in detail. Coming to the structural classification, first one is fibrous joints. Fiber means there is something thready or something fibrous is there in that joint. So bones are joined by the fibrous tissue. Joints are either movable or immovable or slightly movable. Their subtypes are sutures, syndesmosis, and gomphosis. The sutures are present in skull. They are immovable type and united with the sutural ligaments. Their subtypes, the subtypes of sutures, that is plain, serrate, squamous, denticulate, and Syndesmosis type. Plain means internasal suture. Example, serrate is sagittal suture, squamous, temporoparietal suture, denticulate, lambdoid suture, and Syndesmosis type, that is between rostrum of sphenoid and upper border of vomer. So in this picture, you can see there is a plain suture. That means there is no much complication between. Serrate suture means the articular ends are serrated. It is like zigzag or serrated. Squamous type means there is a slanting. And coming to the denticulate structure means just like bricks, two interlocks bricks are being assigned together. In that way, there is a denticulate suture. Then coming to the Syndesmosis, it's specially to the ala of vomer and the rostrum of sphenoid. So wedge and groove. Suppose it's a wedge and it's a groove. So groove and wedge. So the articulation will be like this. So coming to the gomphosis, that is especially to the tooth, there is a socket, and to that socket, something will be fixed. So these are the subtypes of sutures. So we are discussing fibrous articulation, arthrology, and that first one is sutures. Next one is syndesmosis. Syndesmosis means fibrous union between bones, but may be represented as an interosseous ligament and or interosseous or a tense membrane. That is, for example, inferior tibiofibular ligament and interosseous talocalcaneal ligament. So as a tense membrane between sacroiliac joint. So syndesmosis means there is a fibrous joint, but between the articulation that is represented by a tough or fibrous structure. So coming to the gomphosis, that's a third type. That's a peg and socket-like junction between the tooth and the socket. There will be periodontal ligament, which is connecting the dental element to the alveolar bone. So there finishes the fibrous type of structural classification of joints. There are three types: sutures, syndesmosis, even the gomphosis. Coming to the next one, that is the cartilaginous joints. Always remember, for cartilaginous joints, there are two types, only primary and secondary. Primary cartilaginous joints means the joint will be connected with a cartilage, but later it might be replaced with a bony tissue. For example, syphisternal joint or epiphysis and diaphysis joint of the long bone. Secondary cartilaginous joint or the symphysis, that's a fibrocartilaginous joint. In that, there will be cartilage articulating two bony surfaces, but later on, later on the life period of the person, that may not be replaced by bony tissue. The best example is symphysis pubis. Okay, so two classifications are over, fibrous and the cartilaginous. Third one is synovial joints. That's the most mobile joints. Varying degree of movements are possible. Then articular surfaces are covered with a hyaline articular cartilage. Then joint cavity will be filled with a synovial fluid, and there will be partially or completely subdivided by the articular disc or meniscus. Then the joint will be covered by capsular ligament outer. Then there will be a watchdog activity of the capsule so as to restrict the excessive stretching of the joint. So, related to the synovial joint, one more important factor is ligaments. The first one is capsular ligament. Capsular ligament is a true ligament, and there will be accessory ligaments. There will be extracapsular or the false ligaments. They reinforces the capsule. Then, related to the synovial joints, there will be a synovial membrane. As you can clearly see, the synovial membrane will be lining the synovial capsule or the articular capsule, except the articular surfaces. And that will be producing a thin filament of fluid or thin amount of fluid called as synovial fluid. That function is to nourish the articular cartilages. Then classification of synovial joints. So subtype of synovial joints. So first classification is plain or gliding type. Plain. That means articular surfaces are flat. Suppose this is a surface and another one is surface. Another one surface. So both the surfaces are flat. So gliding movement is only possible in this type of joint. Second one is uniaxial joint. Uniaxial means in one axis there will be a movement. That first one is hinge joint and second one is pivot joint. Hinge means a pulley shaped surfaces. There will be flexion and extension possible in this joint. Then coming to the pivot joint, pivot means there will be a pivot surrounded by an osteoligamentous ring. Suppose this is something and there will be osteofilamentous ring. And rotation is the possible movement in that. Then third one is the biaxial joint. In that subtypes again, condylar joint and ellipsoid joint. So the movements are described. Then multiaxial joint, the subtypes are saddle joint, ball and socket joint. So I'll give you some examples by these pictures. So that is A. A type is both the surfaces are flat. That's a plain joint. So that is a intervertebral junction or the articulation in that. Then the articular surfaces of the two vertebrae, articular processes of the two vertebrae articulates, there will be possible for slight movement. That is plain. So second one is hinge variety. That is a joint given for hinge variety. And next one, pivot. You can see there is an axis one and around surrounding that there is a ring. So the atlas as well as the axis movement, that is based on pivot. Then coming to the third one, that is the condylar variety and ellipsoid variety. You can see how the condyles are enumerated here. Coming to the next one, the condyloid variety, the ball and socket variety. These are the example. Coming to the functional classification. So far, we have finished the structural classification. Basically, there are three types: the fibrous joint, cartilaginous joint, and synovial joint. And they got subdivisions. Coming to the functional classification, there are function is easy, like means slightly movable or immovable and freely movable. That is synarthrosis, amphiarthrosis, and diarthrosis. Synarthrosis are like there is no movement at all. That is immovable joints. And that is skull bones are the example. Amphiarthrosis means there will be slightly movable joints, vertebra. Then diarthrosis means freely movable. Elastic connective tissue will be there, ligaments will be there, synovial fluid will be there, membrane, etc. will be present. So, shoulder joints. So, till now we have discussed about the basic classification. See, we have finished the basic classification of the joints, that is structurally fibrous, cartilaginous, and synovial. Functionally, synarthrosis, amphiarthrosis, and diarthrosis. Regionally, we have already described, that is skull type, vertebral type, and limb type. And according to the number of articular bones, simple, compound, and complex. Simple is a simple joint. Compound is there will be multiple bones. And complex means there will be articular disc, subtypes, or division of the components of the articular area. So coming to the individual joints, so we need to discuss individual joints of upper limb, lower limb, even the vertebral joints and the temporomandibular joint. Being a very limited time given to me, I'm trying my level best to limit to the capsule form so that you can refer and you can write for the example point of view. So first joint we are going to discuss is the shoulder joints. Only main joints I have discussed here, but because in a exam point of view, these joints are very, very important. So shoulder joint, there will be articulation between scapula as well as the humerus. So scapula, there is a glenoid cavity, and humerus, there will be head of humerus. These two will be articulating together so as to form a junction of upper limb to the trunk. So introduction, say every joint, when you're writing an answer for the joint, usually if it is long essay, the question will be like enumerate or define joint, then enumerate the types of joints or classification of joints and explain any one joint. That's one form of question. So it carries, if it is a 10 marks, it carries, introduction carries some 2 marks. Then again 3 marks for the classification and 5 marks will be given for the exact joint which is being asked. If it is a 5 marks, again classification and 1 joint can also be asked. So it is better to follow one format for answering the question. That format I have tried to follow in this presentation too. If you are sticking to this type of enumeration, you will be easy. It will be easy for you to fetch more marks. So first one is an introduction. In introduction, you should know we have done the classification. So you should know which type of joint it is structurally and functionally what type of joint it is. Even you can write other 2 classification also. So mainly these 2 are mandatory. So shoulder joint is a synovial joint, ball and socket variety. So articular surfaces, second point. There's a glenoid cavity of scapula and head of the humerus. It's a glenohumeral joint. So glenoid cavity of scapula and head of the humerus will be joined together to form the shoulder joint. So first to support this, there is a coracoacromial arch, musculotendinous cuff, and glenoid labrum. Third point is ligaments. For every synovial joint, first point is a capsular ligament. So capsular ligament, you should write to which area the upper part and the lower part is being attached. To the scapula, beyond the supraglenoid tubercle and margins of labrum. In humerus, anatomical neck of humerus, inferiorly bit below to the neck. Next one is coracohumeral ligament. The root of the coracoid process to the neck. Then transverse humeral ligament, it bridges the bicipital groove. Glenoid labrum, that is a fibrocartilaginous rim covering the margins of cavity and deepens the cavity. So till now, here we can see how the ligaments are there. That yellow colored is coracoacromial ligament. That's a support. The bluish one, then there is a reddish one, that is coracohumeral ligament, glenohumeral ligaments, so as to support the joint. Coming to the bursae, individual, mainly shoulder joint and the knee joint has some bursae related to this. So here it is subacromial bursae, subscapularis bursae, and even this infraspinatus bursae. Relations, this is also important. If you know some muscles passing across this joint, you can write the relations in the easiest way. Even the nerve, artery, vessels, you can write in a simpler form. Superiorly, coracoacromial arch, subacromial bursa, supraspinatus and deltoid. Inferiorly, long head of triceps, axillary nerve, posterior circumflex humeral artery. Anteriorly, subscapularis, coracobrachialis, short head of biceps and deltoid. Posteriorly, infraspinatus, teres minor and deltoid. Within the joint, there will be long tendon of long head of the biceps. So coming to the blood supply, anterior and posterior circumflex humeral, supra and subscapular vessels. Nerve supply, axillary, musculocutaneous and suprascapular nerve. So coming to the movements, that is another important point of a joint. So it is better to write with the muscles which are facilitating the movements of the joint. That carries a complete mark. So flexion, pectoralis major, deltoid, coracobrachialis, and short head of biceps. Usually the muscles which are coming in front, even the pectoral region and even the front of the arm facilitates flexion. Extension, deltoid, latissimus dorsi, teres major, triceps and pectoralis major. Adduction, pectoralis major, latissimus dorsi, biceps and triceps. Abduction, supraspinatus, deltoid, serratus anterior, and trapezius. Medial rotation, pectoralis major, deltoid, teres major, latissimus dorsi, and subscapularis. Lateral rotation, deltoid, infraspinatus, and teres minor. So here I have given one GIF for the. So first GIF is abduction and the adduction. Abduction and the adduction. Second GIF gives the flexion and extension. Flexion and extension. So coming to the applied anatomy, every question should end up with the last point called as applied anatomy. Anything related to the joint or anything related to that point should be written as a applied anatomy. Usually, joints are tense for dislocation. That means it can be it can be glider or it can be moved from that socket. Then there is an optimum attitude of reductions. That is, when we are immobilizing the joint, there should be one optimum angle so as to facilitate easy healing and to do other activities. So here it is 45 to 90 degrees optimum attitude. There is a shoulder tip weight. There is can be referred pain in shoulder tip if there is a gallbladder disease and if there is a irritation to the diaphragm. Since there is a common nerve supply, there can be shoulder tip pain. Then there is a frozen shoulder. That means complete immobility of the shoulder joint. So coming to the next joint, elbow joint. Elbow joint, that is again the joint between humerus and the radius and ulna. So here you can see the bluish depiction for the articular surfaces. There is a trochlea, capitulum, here head of the radius, even the trochlear notch of the ulna uh, takes part in the elbow joint formation. Introduction, synovial joint, hinge variety, articular surfaces that are already described. Ligaments, first one is capsular ligament. So it is surrounding the trochlea, capitulum, coronoid fossa, radial fossa, backside olecranon fossa, radius, the annular ligament, ulna, margins of the trochlear notch. Then anterior and posterior ligaments are there. They are just nothing but the thickenings of capsular ligament. Ulnar collateral ligament and radial collateral ligament. I'll tell you one easy way to remember. Collateral ligaments are always present in lower two joints, that is elbow joint and wrist joint, knee joint and ankle joint. Shoulder joint and hip joint does not have a collateral ligament. So anterior ulnar collateral ligament for the ulnar side, that is the medial side, and radial collateral ligament is for the lateral side. So here you can see the collaterals, even the capsular ligament, annular ligament of the elbow joint, even the joint capsule. So coming to the relation again, anteriorly, watch muscles which are crossing from the arm to the forearm, brachium to the antebrachium. The structures passing from the arm to the forearm are related anteriorly, even posteriorly, medially, and laterally. That is brachialis, median nerve, brachial artery, tendon of biceps brachii. Posteriorly, triceps brachii and anconeus. Medially, ulnar nerve, flexor carpi ulnaris, common flexus. Laterally, supinator, extensor carpi radialis brevis, and common extensors. Blood supply, there is a rich anastomosis around the elbow joint of major branches called as brachial artery, radial artery, and ulnar artery. Nerve supply, ulnar nerve, median nerve, and radial nerve, musculocutaneous nerve. Movements, mainly, it's a hinge variety. So flexion and extension is the possible movements. So flexion of elbow joint is here. That is biceps, brachialis, even the brachioradialis. Then triceps for the extension and anconeus for the extension. Coming to the applied anatomy, see, for elbow joint, there is a carrying angle. Carrying angle means long axis of humerus. When along with the long axis of radius and ulna, there will be a slight variation from the axis. That is 10 to 15 degree. There is a variation. Varus and valgus for the excessive and less angulation. So that is important when we are walking or moving. When we are walking with a swinged arm on the sides, it should not touch the trunk. That's why it is an extended arm. Okay. Then dislocations as every joint, subluxation. Then tennis elbow, student's elbow, golf's elbow. These are different point wise inflammation. Tennis elbow, there can be lateral, epicondylitis. Then student's elbow, there is a posterior, that is a minus elbow, posterior inflammation. In golfer's elbow, there can be medial epicondylitis. Then optimum position for immobilization, 30 to 40 degree flexed. So coming to the third joint of the upper limb, wrist joint. So it's in radiocarpal joint, synovial joint and ellipsoid variety. So articular surfaces, upper and inferior surface of lower end of radius and articular disc of inferior radial nerve joint, lower scaphoid lunate and trachyutral. Remember, for wrist joint, ulnar does not take a part. The inferior radial ulnar joint articular disc will be taking part in wrist joint formation. Coming to the ligaments, there are articular capsule, palmar radiocarpal ligament, again dorsal radiocarpal ligament, radial collateral ligament, and ulnar collateral ligament. So relations: anteriorly, the long flexor tendons, median nerve; posteriorly, the long extensor tendons, their synovial sheath; laterally, radial artery. Blood supply: anterior and posterior carpal arches; nerve supply: anterior and posterior interosseous nerve. Movements: again flexion, extension, adduction, abduction, and circumduction. But there is a slight variety, that is radial deviation and ulnar deviation. The adduction is called as ulnar deviation and abduction is called as radial deviation. Coming to the applied anatomy, rheumatoid arthritis. In that, whenever there is an inflammation, this joint will be infected fast. There is a ganglion. If sometimes you have seen, like there will be some swelling on the dorsum. That's just like a mucoid degeneration of the synovial sheath of tendons. An optimum position for immobilization is 30 degree dorsiflexed. 30 degree dorsiflexed. Subluxation of carpals is also a common applied anatomy. Coming to the hip joint. Hip joint is a junction, it's a articulation between hip bone as well as the femur. So hip bone, precisely acetabulum of hip bone and the head of the femur. So introduction, again, it's a synovial joint, ball and socket variety, articular surfaces, head of the femur and acetabulum of the hip bone. Head of femur is covered by hyaline articular cartilage except of the fovea capitis. Acetabulum is a horseshoe-shaped lunate articular surface presents with the articular notch and acetabular fossa. Special features for the hip bone. It's a hip joint. It's a most unique in having high degree of stability and mobility. These following factors will be giving this stability as well as free mobility. First one, joint deepened by the depth of acetabulum and acetabular labrum. Suppose acetabulum is like this, labrum will be covering the acetabulum, so that the joint cavity, instead of this, it will be doubled, so that head of the femur can be fixed easily so as to facilitate the movement. Then high tension and strength of the ligaments. Whatever ligaments attached to between here acetabulum or the hip bone and the femur, they are very, very tough. And support by surrounding strong muscles. We got so many muscles, numerous muscles passing on sides of or the nearer to this joint. Then length and obliquity of the neck of the femur and atmospheric pressure will be facilitating the special feature of the hip joint. So coming to the ligaments, first one is nothing but the fibrous capsule just above the margins of acetabulum and the nearby bone, and femur, intertrochanteric line and the intertrochanteric crest, there will be attachment. Iliofemoral ligament. See, here you can remember, hip bone consists of three bones, ilium, ischium and pubis. So first ligament you know, capsular ligament. Then iliofemoral ligament, istiofemoral ligament and the pubofemoral ligament. Then from the head, the fovea capitis, it is attached to the acetabulum with a ligament called as ligament of the head of the femur, that is round ligament or ligament of teres. This can be asked in MCQs. Then acetabular labrum, that is also a support. That labrum is a cartilaginous structure. And transverse acetabular ligament, that is acetabular notch, which will be bridged with the transverse acetabular ligament. So here you can see, in a fast way only I'll be describing. There is a iliofemoral ligament, pubofemoral ligament, istiofemoral ligament, and the capsular ligament. You can see the ligamentum teres, even the acetabular labrum, it is visible. So coming to the relations, anterior, posterior, superior, and inferior. So the anterior is tendon of iliopsoas, femoral vein, femoral artery, and femoral nerve. It is posterior, not the inferior. Second point. It's my mistake, sorry. So tendons of obturator externus, quadratus femoris, obturator internus, gamellae, piriformis, sciatic nerve and gluteus maximus. Superiorly, reflected head of rectus femoris, gluteus minimus and medius. Inferiorly, pectineus, obturator externus, gracilis, adductor longus, brevis, magnus and hamstring muscles. Blood supply, whichever artery passing through this joint supplies the joint, like obturator artery, two circumflex, that is medial and lateral circumflex artery, the femoral, and two gluteal, superior and inferior gluteal arteries through the branches. Nerve supply, again it's easy because all the nerve passing through this joint supplies the joint. So that is femoral nerve, obturator nerve, even the superior gluteal nerve. So coming to the movements, there is a flexion, extension, adduction, abduction, medial rotation and lateral rotation. I'm not going into the detailed muscles taking a part in that. You can understand once we are going through the notes. Circumduction is the seventh movement, that is a combination of flexion, extension, adduction, abduction, medial rotation and lateral rotation. Here I have given the first GIF consists of the flexion of the hip joint. Here you can see iliopsoas and the rectus femoris plays a role, flexion. And the second GIF shows the abduction as well as the adduction. So that is again the end of the second GIF shows medial rotation and lateral rotation. Again, the muscles taking part in adduction and abduction, it has been enumerated or it's been shown here. So coming to the applied anatomy, so usually congenital dislocation is possible in that. Again, dislocations, fractures, then tuberculosis of hip joint, then Perth's disease is one more applied anatomy. And in that picture I have given the replacement therapy. Replacement surgery for the hip and knee is the most common these days. And when there is irregularity or when there is there is an injury or there is a condition which is not able to be cured by medical conditions, it is solved due to by the surgical procedure. So with that, we'll jump on to the next joint, that is the knee joint. So knee joint, as we all know, lower end of the femur, upper end of tibia and patella forms the knee joint. Never ever write fibula comes under knee joint. Fibula does not play a role in knee joint. So introduction, it's the largest and most complex joint of the body, consists of lateral femorotibial, medial femorotibial and femoropatellar joints. It is condylar synovial joint. Femoropatellar is the saddle variety. Articular surfaces, again condyles of femur, patella, condyles of tibia. So coming to the ligaments. Ligaments of knee joint is quite confusing. Totally 11 ligaments are there. I'll try to make it simple. Again, if it is a synovial joint, first one should be fibrous capsule. Again, it is a joint of the lower end, so there should be collateral ligament. There is a tibial collateral ligament, even the fibular collateral ligament. Then third one, patella. Patella is attached to the joint with a ligamentum patellae. That's a sesamoid bone. So that is also fourth ligament. 4 ligaments are already over. Next comes direction based. Oblique popliteal, arcuate popliteal ligaments. Oblique popliteal and arcuate popliteal ligament. Then there comes the cruciate ligaments. There is anterior cruciate and posterior cruciate ligament. Then 2 menisci, medial meniscus and lateral meniscus, and the transverse ligament. Hope it is a bit easy now. First one is capsular ligament, 2 collaterals, tibial collateral and fibular collateral. Then 2 popliteal, oblique popliteal and arcuate popliteal. Then 2 cruciate, anterior cruciate and posterior cruciate, 2 menisci, medial menisci and lateral menisci, and finally transverse ligament. So coming to the bursae related to the knee joint, there are totally 12 bursae, anterior, medial and the lateral. So the names of the bursae is not that much important, but you can remember it. That might be asking for MCQs. There is subcutaneous prepatellar bursae, subcutaneous infrapatellar, subcutaneous or deep infrapatellar, suprapatellar bursaes. Then these bursae, 2 medial and lateral bursaes, are related to which and all muscles, tendons passing through this joint. So as to reduce the friction between the tendon as well as the joint and the bone, there will be small pockets of fluid, that is bursae. So coming to the relations, again, which and all muscles or structures passing from the leg to the foreleg or to the from the femoral area to the tibial area, these structures are related. Anteriorly, there is a bursae, ligamentum patellae, patellar plexus of nerves. Posteriorly, popliteal vessels, tibial nerve, gastrocnemius, plantaris, common peroneal, Semitendinosus, semimembranosus, gracilis, and popliteus. Medially, sartorius, gracilis, semitendinosus, semimembranosus, great saphenous vein and nerve. Laterally, biceps femoris and popliteus. Coming to the blood supply, remember 5 genicular branches of popliteal artery. 5 genicular. Genu means knee. So, genicular branches of popliteal artery. Again, femoral artery, there is a branch. Lateral circumflex femoral and tibial artery branches. Nerve supply, femoral nerve, sciatic nerve, and obturator nerve. Coming to the movements are extension, locking, unlocking, flexion, medial rotation, and lateral rotation. For the extension, quadriceps femoris is the main muscle. For a flexion, biceps femoris, semitendinosus, and semimembranosus. Locking and unlocking, locking for the vastus medialis, unlocking by the popliteus. Medial rotation, popliteus, semitendinosus, semimembranosus. Lateral rotation, biceps femoris. Here, first GIF shows the flexion and extension and slight form of locking. So, second GIF, there you can see locked and unlocked. Locked means when it is in standing, when the joint is stable, that is lock. Unlocking means so as to flex the knee joint, it should be unlocked first, then it should be flexed. Then medial rotation and lateral rotation is also being shown. So coming to the applied anatomy, the most common complaint is arthritis. That is again osteoarthritis is more common. Then ligament injuries, sports injuries, ligament injuries are more common. Menisci injuries, the cruciate ligament injuries, or the bucket handle injuries. Then genu, varum, and valgum. That means bowing of legs. The valgum means there will be inward bowing. Varum means there will be outward bowing. And bursitis, the 12 bursas related to the knee joint, anything can be inflamed due to irritation. There is a priest knee, there is a housemaid's knee. These nicknames are for the different bursitis. So coming to the ankle joint, there is joint between tibia, fibula, and the talus. So coming to the introduction, synovial joint of hinge variety, articular surface, upper, lower end of tibia, medial malleolus, lateral malleus of fibula, inferior transverse tibia-fibular joint, ligament, and the lower is talus. Special feature is it is very stable. First of all, it's very stable. That is facilitated by articular surfaces close interlocking and strong collateral ligaments, tendons crossing the joint. Deep superior articular socket, the projected malleoli, inferior transverse tibiofibular ligament will be helping for the stability. Forward displacement is more prone. So the forward displacement of the joint is prone for that injury, but it is prevented naturally with wedge-shaped talus, prolonged lower end of the tibia, transverse tibiofibular ligament, and calcaneofibular and talofibular ligaments. Coming to the ligaments, first one is our nothing but fibrous capsule. There are only two ligaments. First one is medial, that is the deltoid ligament, lateral ligament. So deltoid ligament is a triangular ligament. It's a combination of tibio-navicular, tibio-calcanean, anterior and posterior tibio-talar ligaments. Lateral ligament is a combination of anterior talofibular, posterior talofibular, calcaneofibular, and introosseous talofibular ligaments. The relations, those muscles, tendons crossing the joint are relations, even the nerve artery. So anteriorly tibialis anterior, extensor hallucis longus, anterior tibial vessels, deep peroneal nerve, extensor digitorum longus, peroneus tertius. Posteriorly tibialis posterior, flexor digitorum longus, posterior tibial vessels, tibial nerve and flexor hallucis longus. Posterolaterally peroneus longus and brevis. See, if you know the anterior compartment, posterior compartment, and lateral compartment muscles of the leg, these things are easy. So coming to the ligaments, this here it's depicted. Second one is the lateral view. First one is the medial view. That's a deltoid ligament. Then coming to the movement, two movements: dorsiflexion and plantar flexion. Dorsiflexion. So only for ankle joint, dorsiflexion and plantar flexion. Then the tibialis anterior is the major muscles. Other muscles are accessory muscles. For plantar flexion, gastrocnemius and soleus is the major muscle. Other muscles are accessory. Blood supply, anterior and posterior tibial, peroneal arteries. Nerve supply, deep peroneal and tibial nerves. Applied anatomy, sprains of ankle. Most common. If you are a person if it is a girl, then you wear a high heel, or when you accidentally step on some stone, there can be ankle pain. or if you're a sports person, when you play cricket or when you play football, when you play volleyball, always there is a tendency to get this joint injured. Sprains are most common, and dislocation for the ankle joint. Thus, we finish the joints of upper limb and lower limb. I know it is quite fast, but still, in an exam point of view, we should cover these points. Coming to the intervertebral joints, that's a joint between vertebrae. So the vertebrae from C2 to S1 are articulated from one another by a series of cartilaginous joints between the vertebral bodies and a series of synovial joints between vertebral arches. See, here we'll get two types of joints in one vertebra. That is between vertebral bodies, that is cartilaginous joint, which is a secondary cartilaginous type, that is articular disc, and between the that is the vertebral arches, that is a synovial joint. So joints of vertebrae, there is vertebral bodies, vertebral arches, lumbosacral, sacrococcygeal, intercoccygeal, craniovertebral joint, and costovertebral joint. Maximum for 5 marks only, these things can be asked. Maximum. So that much importance only you should give to this portion. So there is for in general for the vertebral bodies there will be ligaments. First one is anterior longitudinal ligament just in front of the bodies of the vertebra, and posterior longitudinal ligament posterior to the body of the vertebra. Then there will be intervertebral disc. They are symphysis. That is a cartilaginous variety of the joint. Then the chief bond of connection between vertebrae is the intervertebral disc. Shape corresponds to the bodies of vertebra. Then the thickness also varies. Based on the thickness only, we got the cervical lumbar of the lumbar vertebral convexities. You know, we are having normal cervical convexity as well as lumbar convexity. This is because of the variation of the thickness of the intervertebral disc. It is not the variation of the vertebral bodies. Then uniform thickness in thoracic region, that's why there is it's stable. Excuse me. Then it is totally avascular. So the diffusion, through the diffusion only it get nourished. So connected to, there will be anterior longitudinal and posterior longitudinal ligaments. There is the structure of intervertebral disc. It is consist of annular fibrosis and nucleus pulposus. Most common applied anatomy is there will be IVDP, that is intervertebral disc prolapse. There can be fractures and there can be necrosis. So coming to the joints of vertebral arches, that is between arches, okay, that is synovial variety. There will be lamina, spines, and transverse processes as well as the ligamentum nuchae. Here you can see the arches, how they are articulated together. It facilitates only limited amount of movement or immobile as such. Movements of vertebral column, there can be flexion, lateral flexion, rotation, extension, and circumduction. Next one is lumbosacral, the lumbar vertebrae to the sacrum, L5 and S1. It is psychopophyseal joint. There is a large intervertebral disc. All same ligaments plus iliolumbar ligament. Then coming to the sacrococcygeal ligament, it is symphysis joint between the apex of sacrum to the base of coccyx. Intercornual ligament will be extra, and the disc and four ligaments, that is dorsal, ventral, and lateral sacrococcygeal ligaments are also present. There is a craniovertebral joint, cranium. The occiput should join with the vertebra, that is atlantoaxial joints, and there are three and synovial joint. Lateral joints of atlantoaxial joint and the medial atlantoaxial joint, that is atlanto-occipital joint also there. Ligaments connecting axis to occiput boner, membrana tectoria, paired alar ligaments, and apical ligaments. Here you can see the connection between atlas and next one is axis and even the occiput bone. There is an alar ligaments, tectorial membrane. Then coming to the costovertebral joint, it's one more joint which is connecting the costa, the ribs, to the vertebra. Then last joint, that is temporomandibular joint. See, temporomandibular joint is a synovial joint between the mandible as well as the temporal part of the cranial bone. So it's a synovial joint, condylar variety, articular surfaces, upper articular eminence, anterior part of the mandibular fossa, inferiorly head of the mandible. Joint cavity is divided into upper and lower parts by an articular disc. So ligaments, first one is obviously fibrous capsule, then is a lateral ligament, there is a spinomandibular ligament and stylomandibular ligament. Fibrous capsule that is attached to above to articular tubercle, the circumference of the mandibular fossa and the squamotympanic fissure below to the neck of the mandible. It is loose above the intra-articular disc and tight below it. The synovial membrane lines the fibrous capsule and the neck of the mandible. So lateral or temporomandibular ligament reinforces and strengthens the lateral part of the capsule. It is fibrous and directed downwards and backwards, attached above to the articular tubercle, below to the posterolateral aspect of the neck of the mandible. Spinomandibular ligament, as the name suggests, it's from the sphenoid bone to the mandible. It's an accessory ligament. The remnants of Meckel's cartilage. Coming to the stylomandibular ligament, the accessory ligament, it represents the thickened part of deep cervical fascia which separates the parotid and the submandibular salivary glands, attaches above to the styloid process, below to the angle and posterior border of the ramus of the mandible. So coming to the articular disc, it's a novel fibrous plate and represents the degenerated primitive insertion of the lateral pterygoid muscle. Divides the joint cavity into upper and lower compartments so that it is a complex joint. So upper compartment is meniscotemporal, permits gliding movements. Lower compartment is meniscomandibular and permits a rotatory or gliding movements. So surfaces superior. For the articular cartilage, I mean superior concave or convex and inferior concave. Periphery is attached to the fibrous capsule. There are parts anterior extension, anterior thick band, intermediate zone, posterior thick band, and bilamellar region. Previously, when there was 3-mark section, at that time these questions used to be asked, but now it is been included under MCQs. Coming to the relations of temporomandibular joint, laterally there is skin, fascia, parotid gland, and temporal branch of the facial nerve. Medially, the tympanic plate separates the joint from the carotid artery, spine of sphenoid, auricular temporal nerve, chordae tympani, and the middle meningeal artery. Anteriorly, there will be lateral pterygoid, mesenteric nerve, and vessels. Posteriorly, there will be parotid gland, superficial temporal vessels, and auricular temporal nerve. Superiorly, there will be medial cranial fossa, middle meningeal vessels. Inferiorly, maxillary artery and the vein. Blood supply, superficial temporal and maxillary arteries along with veins. Nerve supply, auricular temporal nerve and mesenteric nerve. Muscles of movements. For the depression, for the temporomandibular joint, muscles of movement is important. For the depression, lateral pterygoid, digastric, geniohyoid, mylohyoid, and gravity. Elevation, masseter, temporalis, medial pterygoid. Protrusion, lateral pterygoid, medial pterygoid. Retraction, posterior fibers of temporalis, and lateral or side-to-side rotation. That opposite pterygoids to the left and left lateral pterygoid, right mandibular, medial pterygoid. So here you can see how the temporomandibular joint is getting depressed and elevated. Depression and elevation. Again, here you can see how the rotatory movements, how when you are chewing, how the rotation of the joint happens along with the help of muscles. So coming to the clinical anatomy, most common one is dislocation of mandible. A strong force or strong forceful blow to the mandible can lead to dislocation. And when there is a treatment going for the tooth, usually the molar, extraction of tooth, at that time there can be injuries to the temporomandibular joint. Then rearrangement of the articular disc, there can be clicking and pain during movements of the jaw. When or some aunties or some ajis, when they are, or some grannies, when they are eating, we can clearly hear some noises like kada kada kada. So that is because of the derangement or the derangement of the articular disc. Then chances of injury to the cranial nerve 7, nothing but the facial nerve during temporomandibular joint surgery. So with that, let me wind up the the arthrology topic. I know it is a bit fast, but still, I would like to thank Jignasa for the wonderful opportunity for this class. Thank you.
Thank you, ma'am. Thank you for an elaborative and knowledgeable session on arthrology topic, ma'am. Shall we take questions from the students now, ma'am?
Yes, yes, yes. You can.
Yes, ma'am. Shall I remove this screen, ma'am, or can you switch off present screen, ma'am, so that you will be visible for the students?
Stop screen.
Yes, ma'am. Yes, ma'am. I request the viewers to start putting your questions in the chat box, and I will be reading that out to ma'am. Ma'am, we have our first question.
Hmm.
The question is, ma'am, is it necessary to study metacarpophalangeal joints?
No, for the exam point of view, I will focus on the metaphalangeal joints. Maxima, it can be asked one desirable to know MCQ. That's it.
Okay, ma'am. Thank you, ma'am. The next question is, ma'am, when we write about ligaments of joint, how much how much should we elaborate?
That's what point wise only you should elaborate. Like capsular ligament, where to where. There is a collateral ligament, where to where. Then there will be some accessory ligaments, where to where. That's it.
Okay, ma'am.
Hmm.
The next question is, ma'am, how many relations should we mention?
One or two is enough. More than enough. For that UG level, maximum
Yes, ma'am.
important one to one artery or one more.
Okay, ma'am.
Okay,
The
if
next
you can
question is,
write one or two things relations anteriorly, posteriorly, and medially, laterally, it is well and good. So that if it is a
okay,
5 mark
ma'am.
question, see, usually the mark allocation is like this. Definition, introduction, ligaments, description, diagram, all these carries almost 4 marks, 4.5 marks. So if you write relation also with along with applied anatomy, they can't deduct any marks out of your answer. And you should plan when you're writing exam, you should plan properly how much you should write along with the time management. So it's better not to go for so much of elaboration so that you can save some time and you can stick on to the answers.
Thank you, ma'am. Thank you, ma'am. Uh, the next question is, ma'am, are tibiofibular and radial ulnar joints are important?
Actually, so far it is not been asked that much. Only major joints have been asked for the UG exam levels. But I won't suggest you not to read. You should have some idea. It is comes under desirable.
Thank you, ma'am. Uh, ma'am, the next question is related to diagrams. Like, what are all the important diagrams they should one should remember for the exam, ma'am?
See, one diagram per question is mandatory. One diagram. If in one diagram, for example, shoulder joint, you are able to know draw some glenoid cavity, head of the humerus, and some ligaments related to that, along with a neat label. That will give you ample amount of marks. Okay, whenever you draw some diagram, make sure you are labeling it perfectly. Okay, one diagram per question is enough.
Okay, ma'am. That's a great piece of advice, ma'am. Uh, ma'am, the next question is, ma'am, whether we have to take 50 marks in both the papers to pass, or
Yes,
cumulative of 100 marks is fine. Is the question,
yes,
ma'am?
yes. We need to take two papers, paper one and paper one and paper.
Okay, ma'am. Ma'am, the next question is from our side. Ma'am, since I think less than 2 weeks are left for the exam,
Mm.
what would you like to suggest for the students, like how to prepare themselves to face exam bravely and not to go under any kind of mental stress? And we would like you to wish all the best for them, ma'am.
Definitely. See,
Definitely.
as I always used to suggest
I
my
always used to say,
students and friends, what I used to follow is first of all make some short notes. Short notes in the sense it should not exceed more than 1 page or 1.5 page. Based on that, and it should have the what the apt subheadings, and and it should be concised. It's just like a max. Anatomy is just like a max, and you should know the formulas. You should know the basic or most needed points for the question, and it should be in a presentable form. You can use the flow charts, you can use arrows, even you can highlight one question, one answer, one point you can highlight. And so whoever is valuing the paper should know that you have gone through the subject. Okay, that is first and most important one. Second thing, always manage your time. Always manage your time. How is usually during study leave time, we people will be only reading. Only reading, we will be forgetting to make notes so that your hand is not used for writing, fast writing. So you will be exhausted once after answering 2 or 3 questions. So that you will be constantly throwing your hands, and you'll be feeling tired, you'll feel be exhausted, you'll feel tensed. So always have a habit of writing, constantly writing, at least scribble something, so that your hand will be used for the tension or the force or the stress you are giving for the exam. Third thing, you should sleep properly. You should get enough amount of sleep. Suppose you are a person who is studying at the night. Morning, you will be exhausted. You need some amount of sleep. If the exam is in morning hour, the time of your sleep, if the exam comes, it will be very difficult for your brain to understand or brain to remember things. So you just in this 15 days, you just maintain your timetable. So as whenever the time of exam is there, please don't sleep, so that your brain will be trained. Then drink enough amount of water, because water is the most needful one for your memory, for your freshness. Your cells will be all active and energetic. Then finally, as I always used to advise my students, you should definitely go through the diagrams given in the textbooks. When you go through one diagram, there will be definite labelings. When you read through the labelings, when you read through the diagrams, your brain will be sensing that, yeah, certain things are feeling familiar. So once you go through the description without going through the picture, your brain will feel like everything is new. So as to avoid that, always go through the picture first, then go through the enumeration. So first point is make the short notes. Second one, eat, drink, sleep properly. Then fourth one, habituate the writing. Fifth one, you should maintain your time. That's what that you can make your utilize your the time 3 hours for the examination. Then finally, familiarize your pictures given in the textbooks, so that you will get some connection when you're writing examination, so that you will not feel frustrated like at the end of the exam. So I couldn't do it well, I couldn't remember anything during the exams. So with that piece of advice, I wish a very good luck to the every exam going students, and lots of prayers, lots of love, and lots of blessings. And thank you, Jitnasa, for this wonderful opportunity. All the very best, students.
uh, Thank you, ma'am. Thank you for the advice. I personally, I personally follow that, ma'am. Making points in one page, summarizing the whole topic for every chapter. I will make one page of notes, ma'am. I personally follow that. It's really helpful for me, ma'am. So I
Yeah,
just
thank
I remember that you are suggesting. So it's really beautiful trip what you suggested, ma'am. It really works, and I would request all the students who are watching this to follow the same, because that's not a trick, because you have to summarize the whole topic into one page. So you will be knowing how much you'll be putting in that one page. So it will be really helpful what ma'am suggested. So thank you, ma'am, regarding that, and thank you on behalf of whole team at Jignasa, for agreeing to be on our journey and helping first year students to be part of this whole program, and to extending your warmest support to us. And thereby, and in that regard, we extend our warmest gratitude to you, ma'am. We extend our warmest gratitude and warmest thanks to you, ma'am. On behalf of everyone at Jignasa, I would like to thank you again, ma'am. And we look forward to work with you again in future. We will look forward to meet you once, ma'am, and plan for various programs for anatomy to make it anatomy in a more fun way to learn as possible, to know to make anatomy not instead of like what first year students feel that anatomy is some kind of fearful subject, some kind of burden. To remove that stigma and taboo, we will try make anatomy in more make anatomy a more in fun learning way possible, ma'am. We would like to work with you in regarding that in future too, ma'am, and we require your same support.
Always welcome.
Always welcome. Thank you, ma'am. Thank you again, ma'am. Now I request your permission to end our live session, ma'am.
Thank you.
Thank
We
you.
can.
Thank you.
Thank you.
Yes.
Good
Thank
night.
you. Good night.